Alright. Okay, I see everyone is jumping on, and we are going to get started right away as we are on a very tight schedule. This part and segment of the day is the impact of trauma on the refugee community, and we have the awesome experience to have Dr. Sadi Abdi, who is an assistant professor in the School of Social Work in the College of Education and Human Development at the University of Minnesota. She's a trained clinician and an expert in refugee trauma and resilience. Dr. Adi has worked for more than 20 years with refugee and immigrant youth and families and is the National Child Traumatic Stress Network member. She serves on the NCTSN steering committee as well. Welcome, Dr. Abdi. Also, we have Gwen Sofer, who has worked um, at the Nationality Service Center since 2016 and is the Associate Director of Wellness and Trauma Informed Care, managing on site clinical and holistic trauma informed wellness programming, as well as staff self care and professional development. She is TCTSFY certified through the Center for Trauma and Embodiment at the Justice Resource Institute and has been working in the trauma informed wellness field for over 15 years. We are delighted to have you talk about this most important uh, topic within the refugee community. And now I will turn it over to Dr. Abdi.
Thank you so much, and thank you everyone for attending this training. I am now going to share my slides. Today we are going to be talking about the impact of trauma on refugee communities. I am myself a refugee, and I worked with refugees for now over 25 years, both as a provider, as a clinician, as well as a researcher, and as a professor at the university. My email is at the front, but we will share it later if you need to contact me for any questions. I have no disclosures. The objectives for our training today is to explore the refugee and immigrant experiences. And I usually, even though my area of focus is refugees, we actually work with refugees and immigrants. And I will talk about this later, that line is often blurry, really, for experientially. So if I work in a school, I provide services to both any child who comes here with trauma, whether they're refugees or immigrants. We don't really look at the status. And the similarity is so great that we serve the same community. So just looking at the experiences and identifying core stressors and strengths of this population and what helps and what hinders healthy outcome. And then we will speak about understanding the need for culturally relevant and trauma-informed systems of care for refugee and immigrant populations. And I will provide some strategies for supporting refugee and immigrants in our community. Whenever I do a training or I teach, I talk about positionality and the importance of reflecting on our own identity. I am an immigrant, I'm a refugee, I am Black African from Africa, I'm Muslim, I'm a mother, I'm an educator. All of those identities come into play when I provide services, when I do research, when I speak, because they inform who I am and how I see the world. I also really want all of us to keep in mind about intersectionality. It's not one identity, it's the multiplicity of identities. It's not that I'm a refugee, it's that I'm a Black refugee. It's not like that I'm a Black refugee, I'm a Black Muslim refugee. All of those identities intersect to not inform who I am, but the kind of oppressions and discriminations and lack of opportunities and pain that I face in this world. And I think it's really important for us to think about this intersectionality when we're also working with refugees. So we're talking about refugees today, and it's really important to think about what brings refugees to our communities. How do refugees come to us? And one of the things about refugees is that actually the refugee status is guaranteed by the United Nations. So it is a status that's given to people who by having this status have already proven that they have gone through trauma, that they have a well-founded fear of persecution, of harm because of group membership, because of their race, their nationality, their religion, their gender identity, their sexual orientation, and that they cannot go back to the place of birth. They cannot go back to their country. They cannot avail themselves of the protections that's usually provided by one's country. So it's by nature being a refugee, by this the fact that someone has a refugee status tells us that they have experienced trauma. Um, Refugees and immigrants have similarities and differences. So as I said, refugee is someone who can show, who has proven that they cannot go back, that they have been harmed in their native country and they cannot go back for fear of being harmed more. So a person who's been already persecuted and is afraid of going back. Asylum seekers actually come under the same UN um, status as refugees. The difference is asylee is already in the country in which they seek protection. So a Somali refugee in Kenya is a refugee. A Somali in the US who is seeking to come to stay here can apply as an asylum seeker. And then immigrants are people who cross borders, so anyone can be an immigrant. Often we assume that immigrants don't have trauma because they came voluntarily, quote unquote. But in reality, the majority of the kids I work with came from Ecuador, and they have all experienced trauma because there are countries in this world where there is so much trauma, war, harm going on, but our country does not designate, or the United Nations doesn't designate those countries as producing refugees. So sometimes the status that's given as a refugee or immigrant is political. But immigrants can have the same trauma as refugees, essentially. Internal displaced are people within their country that have been displaced. I've done refugee research for many years. This is an assessment tool that we created while I was at Children's Hospital, and now we use it for the projects that I do across the country and in Canada. And this is called the core stressors and strengths. So we actually identified 4 core stressors that refugees experience once they are here. We already know about trauma, which impacts this emotional regulation, social support. It impacts the whole environment of those kids, those families. We also know that family functioning is impacted. Children are culturally much faster than parents. They develop language skills that parents don't have. Often family roles change so that people, for example, women start working and earning money. Children have more voice because of the culture in the West that they come to instead of just following parents. And that creates huge acculturative stress that can really fracture families. And we also see resettlement stressors. Families are struggling with basic needs, with finances, with legal, if they came here as families that are undocumented immigrants, for example, or if you're working with the new Afghan families that were brought here, but their status is still very uh, unstable. They have to adjust their status. And then, of course, we come here as people of color, people who speak other languages. We come here with our dresses and our food and our languages. And we often face discrimination and loneliness and alienation. So refugees face all of this. And all of this is happening within that context of trauma. So the trauma impacts all those other things. It impacts the acculturative stress because people who have trauma, of course, they are already might be experiencing psychological distress. And now there is those other things that's happening in the family, which can actually increase that distress. People in resettlement, stressors, families may be struggling with, like I said, everyday living expenses and legal issues and health issues, but the trauma makes that even harder and more acute. The same with discrimination. If you have already been harmed because of your group membership, and when you come here, you are again targeted for your group membership. It's like one Somali woman said to me, after America, where are we going to be safe? Is there another place? Is there even, because we waited for 20 years to be here because we felt we were going to have good lives. But here we are, and we are still being victimized. So we had this um, assessment tool, the core stressor assessment tool that we created at Children's Hospital and through the National Child Traumatic Stress Network, and it's shared. It's on the NCTSM website. I can send you a link. But then I was writing a paper with a lot of colleagues this past year, or for the last 2 years, actually, that has been published. And it came to me that we cannot just focus on what is wrong. We need to focus on what's right. Yes, there is trauma, but our families have the most amazing strength to cope and survive and thrive and keep moving despite the trauma. And yes, there is families have, of course, isolation and discrimination, but they have unbelievable social support. And yes, there is resettlement stressors, but those people are resourceful. They made lives in refugee camps. They helped their families survive. And one of the reasons I really wanted to have this strength-based approach is that instead of going to families and communities and looking at what's wrong, we should look at what's right and build on what works. If we would, instead of bringing ideas from outside, the first thing I ask families and communities when I work with is, tell me what helped you. Tell me what works. Yes, you have had all these things happen to you, but you're doing well and you're still taking care of your children, you're working, you're doing all of this. What are the things in your culture, in your community, in you that have allowed you to do that? And then whatever I do, I build on that. So really keeping an eye on the strengths, what's in the community, and building on that is so important. Many of you know about trauma types, but refugees really have essentially almost all the trauma types. Collective trauma, as I said, people are targeted because of their culture, because of their color, because of their religion, because of their group membership. So cultural, historical, social, political, structural traumas are parts of the traumas that they experience. They often have, especially children, because I work with children, adverse childhood events, child maltreatment, domestic violence, sexual abuse, trafficking, all of those things. And then, of course, individual traumas that people have experienced themselves. All of the traumas that we think about, many of them refugees have experienced. And then there is the collective trauma. It is in the community. It is in the family. It is the loss. It's ongoing. And, one of the things we say is that for our refugee communities, there is no post. It's not post-traumatic stress because the trauma is current. It's happening. It's ongoing right now. When we think about refugees, and specifically I work with refugee children, we think about what we call stages of vulnerability, which is times or phases when they experience trauma. And the first one is, as I said, is in the native country. Whether you're in Somalia or Ecuador or in Syria or Afghanistan, when you are in places where there's a lot of violence, young people and families are exposed to armed conflict, hunger, families separation, exploitation, all kinds of traumas. And then during migration, leaving that place of trauma and trying to get to a safety in itself involves more trauma. So mid-migration, family separation, exploitation, assault, illness, long quotes. I will tell you, my own mother, who has never been near an ocean, had to leave her home. She woke up in the morning, there were tanks at her door, half of her house was gone. She walked for 30 days to a place where there was boats crossing into Kenya, and went on a barge for 4 days, not eating, not going to the bathroom, to get to safety. And so that migration to safety in itself involves many losses and much pain and trauma. And then what we call the post-migration, or coming here in places like the US. So let's say even the US, when people here arrive in the US, I will tell you the most traumatic thing is they discover this is not a safe place. The safety and the life they imagine. So letting go of that, because often our families live in places within our communities here where there is a lot of trauma, but there's a lot of discrimination, and that actually accounts for much of what families experience. First of all, they look through the trauma of poverty, fear of deportation, separation, discrimination, loss of status, and so on. But this trauma is actually responsible for the largest share of mental health risk for young people. It accounts for racial and ethnic discrimination is associated with 162% increase in the incidence of health issues. And so people asking me, what do we do about the trauma refugee children and families have experienced because they came from war? I tell them we have to attend to the trauma here. Instead of thinking, I cannot stop the trauma that happened in Somalia. I cannot stop the trauma that happened while people were migrating, or the one that happened in Afghanistan, or like I said, in Ecuador or in Ukraine. We can stop the trauma here. And that's really what should be our focus, is that we make sure that kids in our communities are not traumatized. When we talk about trauma, we also have to think about culture and how trauma is actually experienced through the lens of culture. So in many languages, my own language, my community that I work with, I discover well into my work with community members that there wasn't a word for trauma. And so I have to think about, how do I explain this thing? And one of the things I've learned now is that every community I work with, the first thing I do is gather cultural brokers of people who know the culture and help either find the word that's already used or help me conceptualize how we talk about trauma. What is trauma? And it's not, one of the reasons is because the term mental health in itself is seen as negative in many cultures. There is, as I said, the word does not exist. Words in that, whether it's depression, this whole nuanced thinking about mental illness that we have in the West, the way that it's done in the West doesn't now it exists in other cultures, but maybe in spiritual terms, maybe in terms that are related to the body, maybe spirits that are folklore. So there is ways for communities to make sense of psychological distress. They just don't map into what we see in English language or in Western conceptualization. So we have to really be careful trying to impose our own understanding and our own thinking and our own terminology, trying to make sure the way I approach, because I also do research, is that I tell people it's not the community's language that has to fit in ours, it's our language that has to fit into their language. In other words, if I go to a community, I'm not going to tell them, no, 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 this is depression, this is anxiety. I'm going to say to them, when someone is experiencing those things, what do you call it? And if it's, parts of it is this, parts of that, then I'm going to use that terminology and that approach and that thinking, because I cannot work with a community trying to impose my own view of the world on them. That's just a losing game. And it's not going to work. I'm not going to help them, and I'm not going to achieve any goals that I may have set for myself as a professional. So what I will do is say to them, you set the terms of this work, and I will make sure that whatever I do fits into those terms. And then the places where it's really challenging, I'll work with them to find a way out. Also, often, for example, I work with kids. We do groups for children in the projects that I have in Minnesota. And we actually, a lot of the work we do is focused on the body, because that's how psychological distress and trauma impact is actually experienced. So often physical, that's something that's less stigmatizing and people can express and talk about. In many cultures, psychological distress is associated with the spiritual experiences. So people actually may say, no, no, that person, they are actually connected to the spirits. And so how are you going to tell them, no, something is wrong with this person? You have to find a way to validate and respect that explanation while supporting the patient. Many cultures see also mental health as a private matter. And so how do you get them to talk about it? Some cultures do not even realize poor mental health symptoms are a problem. It's part of the collective. So if everyone in the community has experienced trauma, and many people are having certain trauma affect experiences, then it's not an illness. It might be something that the community has managed to integrate into their daily lives, and you want to work with the community to continue doing that in a healthy way. The other thing about culture that's really important is to think about cultural difference. Again, when I work with people, communities with trauma, and I work with everyone I work, all the work I do is around trauma. One of the things I think about is how do we have a trauma-informed understanding or a cultural-informed understanding of things. And for example, many hospitals have a big problem in cultures where time is cyclical, where people don't think about time ending. So if I had an appointment at 8 and I come at 9, that's okay, because you know what? The hour is still there. Where people may have approach to healthcare where they say God is will, like, you know, how can I trust or spend so much time, invest so much on human mastery and science when I actually believe the only way I will heal, that my illness came from God, and the only way I will heal is by God's grace, if God allows me to heal. Similarly, one of the biggest things I talk to, and specifically around trauma, to providers, is how we tell stories. In American culture, people want facts, facts, facts. And what in cultures like mine, we actually tell narratives. One time, my colleague and I were doing an assessment with a patient, and we asked, we were actually doing assessing the kid, and we asked the parent when when the parents started noticing the child's symptoms or something about the child. And the mother said, when I was 2 years old, and my colleague was like, what? How are those two things even related? We're asking about the child, mom is talking about 50 years ago. And I was like, okay, let the mom tell us what happened 50 years ago. And the reason is, I want to understand the relationship she's making between her childhood and the child's childhood. When we tell those stories in our own language, within the way we tell stories is so important. If you're asking me, uh, this, fact, for example, truth telling, it's not like we lie, it's we tell truth, we control information, so we're giving certain information to people we trust. When people tell me, well, I don't think this patient is giving me all the information I need, providers, I tell them, you know what? Look at that as the level of trust they have with you. The more they know and trust you, the more information you will get. And so telling everyone to a stranger is not culturally something that's culturally acceptable in many cultures, especially in cultures where the relationships are made through historical relationships are historical. So I tell my story to my aunt, my uncle, my cousin, my religious leader, but not to a stranger. And for example, when we do therapy, we expect people to show up and share with someone who is different from them in religion, in color, in experience. How will even this person understand my experience? So really thinking about, again, not essentializing, not saying everyone comes from one culture, and that says collectivist culture and Western culture, that everyone who comes from a collectivist culture is this way, or Western culture is that way, but to really remember, for example, confidentiality, the seeking direction, and so on. Just think about how different is my expectations of how those things will go, given my own cultural lens. How different is that from my patient or the client I'm working with? And so our answer to cultural differences has been to do a cultural competency training, which is defined as the acquisition and maintenance of culture-specific skills. But then we run into this problem, which is much of culture is actually not something that can be taught. This is the iceberg concept of culture. Some of you may have seen it. What's on the top: food, dress, music, visual arts, drama, crafts, dance, literature are things we can see. Maybe we can teach people about our food. We can teach them about our dance. But much is under the surface, and that we cannot teach. So if your institution is depending on, I work with communities, refugees with trauma, and we know we have to understand their culture to be able to serve them equitably. And our answer is to do training, cultural competence training. It's not going to work, just so you know. Because there is a lot, the unspoken rules, the unconscious rules, completely below sea level, emotional load. Those are the most important thing, the things that will determine whether the client comes back or not, whether we are doing harm without knowing or not. So to really keep in mind that cultural competence is not the answer. It is part of the answer, but not the total answer. So we go to cultural humility, which is actually a commitment to self-evaluation and self-critique. So you're looking, instead of thinking of lens through which you're seeing the world, you're actually looking at yourself, you're turning the mirror to yourself, you're learning about yourself, recognizing power imbalances between you and the patient, between the institutions and the community we serve, and attending to those, and really developing mutually beneficial partnerships with communities, and having a social justice lens. We cannot say we want to heal and ignore discrimination. It just doesn't work. So we really do have to think about, is my institution, is my work, is my interaction with those communities just? And so we can do cultural competency because we can still learn some things. That's okay. But it's what we say, what to say and do, and what not to say and not to do. It's concrete and goal-oriented. Cultural humility, which is what I teach my students, is a stance. I tell my students, I'm not going to give you the answer to meet every culture, but I'm going to give you a stance and approach towards engaging with other fellow travelers in the world, a way that you can meet every culture. And it's a values-oriented focus on increasing connection and dismantling oppression. Any community we work with, so any one of you here who works with communities, it is so important to understand that specific community. So this is actually the research we did with Somali communities in the East. And we looked at what were the barriers to mental health care, distrust of authority. So linguistic and cultural barriers, stigma, which I talked about before. So the shame attached to mental illness, and primacy of resettlement stressors, so that resettlement, housing, and so on. So what we said was, okay, we have to address those barriers. The first one, we actually addressed it by having a huge community engagement, going to mosques, those were Muslims, so mosques, going to community events, just talk about trauma, talk about how it impacts cares, talk about mental health, normalizing the seeking of behavior, or health-seeking behavior around trauma, and so on. And then we also built partnerships, linguistic and cultural barriers we addressed by building partnerships with cultural experts, and we created what's called cultural brokering. We're using cultural brokers. And so again, we didn't want that to be the issue. We didn't want people not to come because there were no language support. The stigma, we said, okay, if we just talked about, because the community said that to us, if you're always talking about mental health, people are going to hate you. If you're always talking about trauma, which is a painful thing, people are going to say, this is the person who reminds me of the bad things that happened to me. Instead, let's talk about housing, if that's what people want. In our case, people really said the only place they will seek help, it was in school. So our model is a school-based mental health for kids. The reason is because kids come to school and we wrap everything around child's education. So we are talking about helping children succeed by attending to their psychological wellness. And then primacy of the resettlement, we actually said, okay, we want to have case managers, cultural workers that do concrete services. So linking families to housing, to everything else that we know is causing distress, is actually making the trauma effect worse. So for all of you, this is really like a model to take. Think about how you can do at first in your communities, do community level education. So really going out into the community, again, partnering with the masjids, with the churches, with the temples, and making sure that, one of the things I personally did, and when I was in the East Coast, is work closely with the religious leaders, ensuring that religious leaders understood trauma, understood how it impacts people's psychological wellness, and that they can, as religious leaders, they can speak with authority about the need for mental health care. And then more than that, we actually set up a clinic, essentially not a clinic, but a triage at the masjid in Boston, so that there was a psychologist there every Friday when 1,500 people came. And if someone came to the imam, which is the religious leader, and said, I have these issues, and he spoke to them and he thought they needed mental health services, we had someone who was there for free who will talk to the client, to the person who came to the imam. And we had a group of us on WhatsApp. So the clinician who was there, a psychologist, who will actually text all of us and say, I have this person, this is the insurance they have, or they don't have insurance. Can someone pick them up? So we built a whole system to care for patients within the community, in a place that was in the community. And then if you're an institution that's healthcare provider, like a hospital or a clinic, really doing provider and patient education around this, and specifically I never do trauma training without culture, and I don't do culture training without trauma. I do both. So really twinning those and ensuring that your clinicians understand, because we can bring patients to the door, but if the services provided are harmful, the patients will bolt and will never come back. So the first thing we do is work on ourselves, as providers, as community leaders, as healers, to work ourselves so we are actually a safe space for patients to come. And then for those patients that are identified that might be receiving services that are referred to your clinic or to wherever you're working or to a community provider, ensuring that we are tailoring services to their cultural needs. So understanding how does that patient understand, and mental health, what are the things that will make engagement work? Again, really like going back to those barriers and understanding the barriers for that specific community and ensuring that you're tailoring. But more than that, even in the session, thinking about how can I, make this patient feel at home, feel safe, connected, so they come back. It's always about the next appointment. Like if a patient comes to the first appointment and all they do is sit there and not answer many questions, that's fine. As long as you can bring them back to the next appointment, the next appointment, the next appointment, and you're accessing cultural supports, you're understanding what are ways you can engage that patient. The cultural support, we do it with cultural brokers. If anyone is interested in learning more about this, please email me. But we use cultural brokers who are trained professionals who are from the community, but who also know the systems well. I will say partnership. It's really important to build equitable partnerships with communities, with refugee communities, agencies that provide services to the community-based programs and organizations that serve that community. Whenever I work, like I go to many different places to do this work, I always ask where does the community go? Who are the people that if you go to their office and just sit in the waiting room, you will see many community members of the people we want to serve coming there all day. Those are the people I want to partner with. And again, having cultural brokers, partnering with trusted community institutions, including religious institutions, community-based ethnic organizations, CB, yeah. And then being experientially relevant, really ensuring that you understand what those client is, what those community members, what the trauma, the types of trauma they have gone through, what are their sources of pain, things that they have experienced, what will trigger, what will remind them of those, like discrimination, huge reminder, like I said, if you came here as a refugee, you have been persecuted, you have been harmed, your family has been killed because of your identity. Anytime here you see the same thing happening, that because you're Black, you're Muslim, you have an accent to being attacked, it's a reminder of all the harm that you have already gone through. The other important thing is in Western culture, everything is fast. I say that the speed is about even if we're doing nothing, we want to run. And engaging community members, working with trauma in a trauma-informed way, working cross-culturally requires that we slow down. That we may have, and I know that's very hard for the providers, but we may have a list of things or a list that we want to achieve. So we have our list. I'm a provider. I know, there's the insurance forms, there is the documentation forms, all those forms that we have to fill. But if we're not engaging the patient, all of those just become, the work into themselves. We are no longer serving, we're no longer prioritizing the client, we are prioritizing systems and processes and so on. So it's slowing down because other cultures, people from diverse cultures have a different ways of building relationships. Um, Sometimes, like in my own culture, in African culture, we actually, it's really important to ask how you say hello. This is even outside of trauma. And then trauma adds to that. Okay, whether you care about me, whether you are someone who respects me. I had a long time ago, I used to do this training, provider trainings for a hospital. And I will invite community members, patient communities to actually come and talk about their experiences at the hospital. And I invited young Sudanese boys, and they were sitting there, and there's all these doctors sitting, like it's a lunch, sitting, listening to them. And one of the doctors asked them, what was the hardest, what was the most difficult thing when you came here for you? And the young person goes, why do you ask us why we are here? And the doctors were shocked. That was really hard. That's what doctors ask people. Why are you here today? But for the young people, it meant that you didn't remember me. You didn't respect me. Like if you gave me disappointment, like a 20-year African immigrant is not a refugee, actually, it's not going to come to appointments. It's very hard to get them to go for primary care appointments unless they're sick. And so these kids were coming because of the refugee health assessment. And so you gave me this appointment a month ago. It was required of me. You gave it to me. How can you not remember? That was an injury to those kids who have spent a lifetime trying to feel safe, trying to escape persecution and being mistreated. And the doctors here were just doing what they always did. That was the harm. You cannot do what you always did. You need to really be cognizant of the community you're serving. Where are the sources of pain? What is the harm that has been done? What are the types of trauma they have experienced? What are the cultural nuances to talking to them? And you have to be every single thing, every moment of that, especially in the beginning. Those sessions have to be very focused. The other thing to do is we need to know what is in the healing toolkit of our communities, of the clients we work with. In other words, people came to us for generations. They've been healing themselves from all kinds of diseases in their own culture, with their own beliefs, with their own practices, and we expect them to disregard all of that, come here and tag on our beliefs and our belief systems and our approaches. When you think, the simplest medication, uh, penicillin, antibiotics, worldwide used, if this culture had other ways of treating that disease, what makes us believe that they should disregard, or that they're going to automatically disregard what they've done thousands of years and tag on what we think will work? What is the evidence they have that what we're giving them, and why would they disregard their culture? And so really understanding what is in their own toolkit and building on that and showing respect for it and explaining why they can keep what they had before and add to it is so important. So, for example, when your clients talk about mental health, what words do they use? Just saying, tell me, are they using the word crazy? Are they using spiritual words? Are they using cultural words? And how do they make relationships between what that person is experiencing and the unhealthy or illness and so on? Also, where do they usually go? I always ask my clients, where do you go for healing for this? Because it helps me understand what they expect from this session. Often a big bad thing happens in our care systems because people who have completely different understanding of what it means to go to a healer come to us, and we don't ever ask the question, why, what is your expectation of this? For example, in many cultures, actually schizophrenia, I work with a lot of kids with, well, not a lot, but kids, number of kids with schizophrenia, and it is very hard for them or their parents to understand that this child will have to be on medication for a long time, for life. They will say, I brought them to the doctor, they're doing very well. Why do they have to take this medication? This medication is, and the child will say, of course, this medication is making me feel this, and I don't want it. But the point is because it's very hard for people to understand chronic diseases. And when someone takes the medication and they feel better, they feel, okay, I've been cured. And so it's really important to have that conversation about and to be sure that they are understanding what will be the treatment, how long it will last. So asking them, who do you go to before? What kind of healing? Why them and not? So why did you go to the sheikh, which is the religious healer, and not to a hospital? Like, so what are people, why are they going to one place and so on? And then again, what does healing look like? What do you expect from this? And making sure that you and they have a common understanding of what the healing is going to be like. So I do a lot of work around engagement, because if we're talking about trauma healing and healing in general, we cannot heal if we don't engage. We need to engage people in a relationship, and we need to engage people in the services that we provide. So engaging them in care. Often patients will go to one appointment and will not come back because of what they have experienced, the harm they've experienced because of discrimination, because there's no one who speaks their languages, because the doctor or the provider did not value their input, did not value their practice, did not value what they have done before. And so really engagement is a huge part of what is the primary part of actually healing. We cannot heal from trauma without engagement, without actually building a relationship. So it's about relationships, it's about respect, it's about reflexivity, which is really looking at yourself, turning the mirror to yourself and understanding yourself, and reciprocity, which is those relationships with communities. Again, number one is practice cultural humility, know yourself. Be a partner with both the patient but greater than that, really knowing your communities that you work. If in your community where you're working, in your clinic, in your hospital, wherever you're in the school, wherever you work, and you're seeing a number of patients, refugees, for example, which is the group I'm talking about, building relationships, going out, holding spaces where people gather and talk to each other and understand each other is so important. It is ironic to say to a group of people who are attending trauma training, be trauma informed, but I think we always forget that trauma informed is about safety. So if there is a discrimination, there is a harm done, if there is a lack of care, if we are making people feel unwelcome, all of those makes you not trauma informed. Looking at real whether the environment in which you provide services is a safe environment for all people, and identifying moments of harm and taking accountability. And accountability does not just involve acknowledging and apologizing, but actually instituting change and ensuring that that behavior doesn't happen again. Then you are not trauma informed. I have worked in so many systems, in hospitals and schools and other care spaces where people who have been trained to care, who've been trained to be trauma informed, have done so much harm. And they often do so much harm with best intentions. Your intention does not count. It's not about intention, it's about impact. And so, many people, much harm, as far as I'm concerned, and the work I do has been done with good intentions. So if you feel like, yeah, I know, I'm really good at this. No. Examine yourself. Practice cultural humility, both as an institution, as an individual. And finally, be culturally relevant. Mental health is such a culturally bound care. We make sense of it's like no other service. If you broke a leg, you can go to anyone as long as you think like a doctor. They can set attend to your broken leg. Hopefully you will be fine. If someone is, what I say is, either it depends how even the language we use when we talk about different cultures, psychological distress. in my culture, we actually talk about the heart and we talk about the soul. We don't talk about the mind. So if your heart or soul was hurt, you don't go to strangers to make it right. You go to people you trust, people you respect, people you think they understand you, people whose values align with yours, right? And so we need to be really careful. If I am someone who has done this work for over 20 years, who does trainings literally every other week, and who I will tell you sometimes gets very depressed just thinking about how little we have advanced, how bad we are at this. I will be for the next whole week, Monday to Friday, I will be in DC at the SAMS gathering. And I will talk about that. That's what I will talk about is how bad we are at serving communities who are, either minoritized or different culture, have different culture. Because we think whatever we invent for the white culture is going to be good enough for everybody. And sadly, I can tell you, no matter how beautiful your intervention, if you cannot make it relevant to the people you're serving, it's absolutely useless. It's not about the intervention, it's a capacity to do something, to heal, to cure something, or to actually to be effective. It is capacity to be effective for this specific community. So I talk about overall services that provide trauma-informed and socioculturally relevant care can be powerful tool for promoting healing and recovery among adults and children who have experienced trauma, refugees, but others as well. So these services can be really powerful tool, but we need to change how we do things. How do we promote healing and resilience? And resilience is interesting because when I talk about resilience, again, those are the terms we keep in mind and think about. What does that look like in different communities? For refugees, it's actually the capacity to keep moving forward. It's not bouncing back, because bouncing back is a very Western way. It is the capacity, it's what they have always done. How do we help people keep doing what they're doing, but do that while healing, while becoming even more, while having hope? How do we instill hope and build a hope? So it's not so much bouncing back, but how do we keep people advancing and healing and moving forward? The way we do is, first of all, education for the providers, education for the community, education for the funders, education for everyone so they understand the needs of this specific population that has already gone through so much. That comes to us seeking refuge. The word refugee includes refuge. So seeking refuge, safety, and yet find harm here, okay? How do we make sure that we create safe spaces, a safety? If we don't make people feel safe psychologically and physically, okay, we cannot. Trauma is about harm having been done and the expectation that more harm will happen, and the vigilance, like being aware and being scared that more harm will come. How can we tell people to heal and to not have those trauma reactions if we know for a fact they're not safe? So safety is everything. Safety is the foundation upon which healing is built, okay? And I don't use the word empowerment. I would rather use the word like ensuring that we are not taking power that does not belong to us, that we are making sure that the community power that belongs to the community stays with the community, that the power that belongs to individuals that we serve is often people will come to us in need, and because they're dependent on care on us for care, we take more power than we should. So really going back to the cultural humility and working towards that, ensuring that the power imbalances are addressed, ensuring that you are not taking power that doesn't belong to you. So it's not empowering because that implies that we're giving them power. It's actually being equitable and working toward social justice and not taking power that does not belong to you. Collaborating. And then I don't actually, self-care is another one that I use that word because that's what people talk about, but I talk about sustainability for those who do trauma work. We are also embedded in trauma. Many of us, those, especially if you're working with refugees or immigrants, people who have themselves experienced trauma and who are from the community, I do a lot of training for culture brokers and interpreters and providers who are from the community, ensuring that they themselves are protected and that we are taking care of them. And often the words I use is sustainability, because what I'm saying is that they will say, I can't stop because I care so much about the community. Taking care of yourself is not a selfish act, it's an act of actually an act to protect your community, because your services are so important. By caring for yourself, you are caring for the community. Thank you. I think I just gave back 5 minutes or 4 minutes. I know there were so many words in the chat. So Gwen, I'm going to hand it back to you.
Yeah, thank you, Dr. Abdi, for that wonderful presentation. I'll start off with a few questions that I gathered along the way. You had mentioned some barriers that people experience. And there's so many barriers, but the first barrier to services is always language access. So can you talk about a little bit about mother tongue and how important it is in the context of therapy, and also how you would suggest people advocate within their agencies or wherever they're working for language access for clients?
Thank you, Gwen. This is actually an amazingly timely question for me, because I just came back doing training for interpreters. And so one of the first things I want to just put out there is language access is way beyond words. It's not about, taking the word green and saying the green, is this word in Somali. It's actually a much greater providing context, helping the provider understand. It's not just green. Green means this in the culture. Green implies those other things. And so providing that, one of the real struggles that we have is that often we have thought about interpreting as a conduit. And providers are very resistant to change that process of where, the interpreter is a conduit between the provider and the client, and you don't change, you don't add, you don't do anything, you do. My own preference is that we do more and more. And so there's a whole process, a manual. I actually was one of the people who wrote it at the NCTSN that provides how to use interpreters in a more effective way. So for those first of all, I think the first thing would be to increase people who speak the language, who are providers. So like myself, like I speak multiple languages, but for example, in Somali, I can serve clients. In Somali, I work with Latina kids. We try to get as many Latina providers as we can, because you're removing so many things. You're removing the need to interpret, you shorten the relationship building time and so on. But as we work towards that more equitable world, if you're using an interpreter, work with your interpreter. Don't see them as an enemy that you have to control. See them as a partner that will enhance your engagement, treatment, communication, and treatment adherence, and ultimately will improve outcomes for your patient. So one of the things we encourage is meet with the interpreter like for 2 minutes, 5 minutes before the session. Talk to them after. Have a sign that says, if there's something, for example, one of the things the interpreter told me when I was doing this training was the patient will turn to them and say, well, I'm going to tell you all of this. Don't tell the provider. Even though the interpreter had told them before that everything has to go to the provider. And then they're saying, like, if I told the provider everything that the patient just told me, and sometimes the patient will tell them the story and then tell them, don't tell the provider, then the interpreter will feel horrible because they just, betrayed someone from their country. But then if they don't, then the providers get mad and say, well, you guys have been talking for an hour, and why did you talk to them without telling me what they said? So there's so much going on. Allow your interpreter that moment to say to the patient, I have to tell the provider, I am really sorry. So if something is happening, you don't understand, instead of getting mad at the interpreter, talk to them, say, okay, what happened there? I want to understand, and how do we plan for the next time that can happen? So there is a lot, we need a lot of training for interpreters, but more importantly, which is harder, we need a lot of training for providers to help them how to effectively use interpreters. I hope that answer, it was a long answer, but I'm very passionate about this part.
Yes, yes. Well, I'm with you on that. We struggle with that whenever we're referring people externally. And you had mentioned cultural brokers. We have similar situation at NSC, and it's so amazing when the interpreter, the therapist, and the client create a therapeutic triad, and
Absolutely, yes.
the interpreter can serve as a cultural broker if there's something said in a certain way that might be offensive or hurtful for the client. So thank you on that.
Absolutely.
You also mentioned the stressors once people are in the US, and connected it to resilience, of course. But I'm wondering if among those stressors, you've seen an increase in people's distress during this time of heightened world events, increased xenophobia and racism in the US, and also the threats of policy changes, particularly with the new election. Are you seeing that as an increased stressor in the clients that you work with?
Absolutely. We're seeing that, and I hope everyone will keep eye on that. Every time, it's not just seeing them. I actually, a few years ago, we did this research at Children's where we looked at a refugee group, seeing when the politics of immigration were really heightened, and especially with deportation and the Muslim ban. And we actually saw change in their psychological distress with those youth. And so, yes, it's already people, specifically people with either a refugee status or even a green card or undocumented, are already living under conditions that are uncertain, that are very scary. And so anytime you have events like what's happening in the Middle East, the event is with with our own national political sort of atmosphere, people start feeling unsafe. And it doesn't have to be, there doesn't have to be a straight line between that individual and what's happening. For example, war is a reminder of what drove refugees. So anytime there is a war and you're seeing war on TV, refugees often have re-experiencing, they may have trauma reaction to what's happening. And then anytime you have political discourse that is, specifically targeting immigrants, you have that reminder of, I used to say, I would say this, I'm gonna, say it about myself, when for a long time I had 3 passports, 3 residences, like 2 passports and residence, because as a refugee, I never felt safe anywhere. So it was like, if I have to leave this country, I'm gonna make sure I have another passport. And so, yes, that it's constant. And I think for those of you who work with those populations, you don't have to dig. One of the things about refugee trauma, I talked about how people really had this strength of and coping strategies or skills that allowed them to not only survive, but thrive. And so please, anyone here, don't dig into a trauma if people are not ready, because you don't want to open wounds that are really hard to close. When people are ready, they will seek help. On the other hand, if you see a patient or a client or a kid you're working with, if you see changes in behavior, if you see, greater sort of withdrawal or hypervigilance or, crying or things like that, then you can think about what's happening in the world and how that may be impacting. Specifically, if those kids are kids who are from our southern border, whose parents are undocumented. Imagine every morning if your parents are giving you a number to call in case they don't go home when they go to work. I mean, what the level of trauma, or if they're Muslim. I mean, a lot of our clients who are Muslim kids that I work with, because I work with Muslim kids, are experiencing right now very much a lot of pain, partially because there is something that people have always, some people have talked about, some did not, some felt was true, some did not, which is, does this country care about us? And people like us are coming to the forefront. And I'm going to just say that people are really like that. That is the thing, is like, do we matter as people who live here?
Yeah, thank you so much. And that also reminds me too that oftentimes people's concern for family and friends back home is also on their mind all the time, and this sort of sense of limbo that can really have a negative impact. Thank you.
Thank you.
You also talked about cultural humility, and one thing that always sticks out to me is how so many therapeutic interventions are Western focused, Euro focused, and what is your recommendation for people if they're trying to infuse this cultural humility into their work, and particularly around individualistic approaches, which I think a lot of interventions are focused on, and the collectivist approach, which so many immigrant and refugee communities have embedded in their beliefs?
So thank you so much, first of all. That's really important question. There's two parts to it. One is cultural humility, which is about ourselves. So I teach MSW social workers. I teach students who are going to be ready to go out and provide services to communities and families. And one of the things I say to them is you cannot serve anyone unless you know yourself. For example, we have a child welfare program. Some of our students are going into the child welfare stream because we have 4E program at the U. And so I tell them, ask yourself, what does a healthy family look like? And how do you know this? So of course, you know what healthy look like because of your culture, because of your community. So a healthy family is a very specific, culturally specific way. This is more like looking at a mother, maybe anyway, whatever you see it is your culture. It's how you're learned. So if you're going into a family's home and you're looking at, for example, how parents are interfacing with the child. I was talking to a cultural brokers about this yesterday too. For example, if the child is running around and a parent is not giving any directions, in Western culture, that may be seen a 5-year-old running around doing whatever they want as a bad thing. But in actually my culture and other cultures, that is seen as good parenting because we allow the 5-year-old to do whatever they want because it's time to be free. Now, when we send them to school, they run into a problem because now they're going to do everything they want and then that child is not ready. So cultural humility is first for checking in yourself and in your institution. What assumptions are we making about the world that we are imposing on our clients and so on, right? The other part of your question has to do with in-sessions and how we approach, for example, collectivists. What I tell clinicians is when you work with someone from my culture, there are 10 other people in the room with you, but you don't see them. You may as well put it on the table and say, okay, who else is with us? Who else is going to make this decision? Because often clinicians will come to me and say, Saida, I spoke to this person. They said yes, yes, yes. And then when they left, they never came back. Or when they came back next time, they said, no, no, no. And I don't understand what changed. What changes? She called grandma in Somalia and she was told no, no, no. And now she has to follow grandma. You may as well approach the care as a collectivist and have, even if the parent is showing up by themselves, know that there are 10 other people who are involved in that decision. And putting it on the table, and as much as we can inviting some of those people, as long as, because sometimes people will say, I want to bring my aunt, and we'll say, no, 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 this is for you. No, if they're giving that permission, maybe the aunt is the person who's going to make the decision. So the more interaction you have asking that question, who else are you going to talk about? Who else is going to be involved with this decision about the care? And would you like me to help you think about how you're going to share this information with them? Or would you like me to meet with them with your permission and have this conversation? If you put it on the table, it is there. So.
Yeah, I love that idea of who else is in the room. And that does really remind us of the perspective that we need to have. Wonderful. So in the work that you've done, and it sounds like you've been in the US for quite a while, and all the professionals that you've run into in the mental health field, what would you say are the biggest assumptions that people make that you've heard?
Assumptions about assumptions.
Yeah, assumptions, I guess, about like going into this therapeutic space. What assumptions do you see therapists make when they're working with patients from a variety of communities.
Thank you. That's actually easy for me because I'm going to the SAMHSA thing next week, as I said, and there's a smaller SAMHSA meeting that will take place on Friday that I'll be a part of. And this is what I'll be talking about. It's the assumption that because interventions have been tested and are evidence-based, that they will work on everyone. No, they won't. If you're taking CBT, I studied CBT in college. I thought I will never ever use it with my community. I actually use CBT, but I use an adopted CBT for that I have adopted. That makes sense. If you think that an intervention that is Western, that is developed in this culture, or or a healthcare that we've built. I come from Boston. Well, now I'm in Minnesota, but I lived for 20 some years in Boston. I lived, some of you may know Boston, I lived in Brookline, right next to the medical area. So the best medical centers in the world. And you know where refugees went for healthcare? They went to clinics in the community where language and culture were accessible. They didn't go to the big hospitals. They could not be found entering those spaces. So just because we built, no one is going to come. We are so focused on building beautiful interventions and building beautiful buildings, thinking they will be serving everyone. No, we need to really, really examine and be careful. We need to build specific, tailored care for these communities. That is the only thing that's going to work. So the assumption that things that work for one will work for other is the one that I fight against every day.
Yeah, so true. And I think there's also a lot of letting go of control that
Oh,
comes.
yeah.
And of course, all of us probably want to have all the control. But I think what we've observed is it's really sort of retraining yourself to not have to be the expert in the room. You could
Absolutely.
share an
Yeah.
expertise
Yeah.
with the client.
Yeah. And that I use what I call the competency, letting go of the competency, because I think, and the comfort, because actually feeling like you're the expert in the room and that you know what's happening and that you control is a comfortable space. And actually, every time you enter into a relationship with people from another culture, people with trauma, with patients who are very different than you, you have to enter with discomfort and with a sense of ignorance that you don't know, that what they know is going to be, they are the experts. And when I was doing that training for interpreters, I had that, you were talking about the triad, and it had the provider expert in the clinical intervention, the interpreter expert in both languages, but the patient is expert in their trauma. They know, and their culture, they know what they're experiencing, and they know what they need. And if we don't listen to the patient and learn from them, so going in as learners and having a discomfort and awareness of your own incompetence is very profoundly necessary.
Yes, thank you so much. So I think we have time for one more question from me, and then opening it up to the rest of the room for questions. So going back again to sort of the stressors post resettlement or post coming to the US. One thing that we see a lot, and I'd love to hear your input on it, is the changing dynamic between the children and the parents and even the grandparents, as children tend to adjust more quickly and sort of adopt maybe a more Americanized approach, and maybe the language, whereas the parents and the grandparents might not be doing that quite as rapidly. And what do you see as far as what clients share with you, whether they're the child or the parent, in regards to that? And we have about 5 minutes left.
Oh, good. So I will talk greater because I actually do. That's one of the research areas that we look at right now, in my research for the last 20 years. So we do a lot of work on acculturation and do a lot of, and acculturation is what two things drive. If you're sitting in a clinic or a mental health or a hospital, mental health services, the families will come to you, not necessarily because of trauma, but they will come to you because of acculturative stress. So fracturing of family relationships, like you said, child parent, spouses, because of the changing roles. And because children, as you said, become much more acculturated, they may adopt culture, like language and culture, and more importantly, how we interact with each other. So how to speak to parents I come from a culture where you don't look at your parents in the eye, and the kids go to school and they're told, look at me in the eye. And so they go home and they might be looking, the parent in the eye. So now it's like you're challenging me because you're looking me in the eye. Or the child may say, I want to negotiate this. And the parents say, negotiate, are you negotiating with me? That's it, because of course in my culture, no one negotiates. The parents tell you what they want and you do it. And so that whole thing, and specifically, this is really important for those of you who work with cultures where there is a distance between the American culture and the culture of origin. So if you are Bosnians, even I worked with Bosnians are very westernized. When they came to the US, they came from Germany, so they already have that Western approach on life. The sort of the cultural stress may be less because the culture, once you learn the language, which was fast, you lose the accent, you look wide, and there were not a lot of demands from the culture that said you cannot do A, B, C, D. Tech Somalis, which when I was working with the Bosnians, it was Bosnian and Somali community projects, school-based project. Somalis are Muslim. The girls are supposed to be wearing the dress that I'm wearing. The language is different. The color, we're black. And so the distance between the American, okay, I should say this, the American mainstream culture, not the American culture, because America has many cultures. The American mainstream culture and the Somali culture is very, it's a very large difference. And so the acculturative stress is much higher, and it's higher for girls. So in our research, what we found was that actually for boys, becoming more Americanized was protective, because if a boy is wearing shorts, playing basketball, speaking English, he wasn't getting a lot of pushback from the family, and he was able to integrate much faster into the American. So it was actually reducing the stress on that child. So they were, for girls though, if they became too Americanized, meaning that they started wearing dress that's different, speaking English, and not doing things that are expected, or, feeling the role for a Somali girl, they actually were getting more psychological distress, even if the trauma was similar. So they were getting more psychological stress because of acculturation, because they were stepping out of the norms in the Somali culture. So they were getting harmed in their culture, but also because in the Western culture, maybe they were still wearing the covering. So they were still getting like discrimination, and they were losing the social protection in the family. And so you will actually see a lot more families coming for help in mental health because of acculturative stress. And the sad part is not many of our clinicians, if they're not aware or learn what that looks like and why that's happening, are not able to help. Again, also the other thing I'll say is gender role is husband, wives, because women's role changes when they come here. They got a job many women may get a job for the first time. Many refugee women, they may have their own bank account, independence. And so that also creates, so families like, I work with Syrian families, Arab families, Afghan families, Somali families, a lot of other African, actually Christian, Muslim, there's so much change happening culturally between the two cultures coming together because of acculturation, that's often what drives the psychological symptoms that people seek help for.
Yeah, thank you so much, Dr. Abdi. I appreciate those answers. And I'll be handing it over to Anne for the open questions.
What a vibrant and wonderful presentation and discussion. Dr. Abdi, I am so delighted to hear yours because it so aligns with a lot. I am a anti-racism bias supervisor as well as a clinical supervisor. So a lot of what you talked about, especially around the culture of humility, I am constantly fighting people to stop saying the word competent. You cannot be competent. I'm barely competent in my own culture. So let alone being competent in someone else's. And so humility is so important, regardless of what culture that you are facing. So thank you for that. I want to lift up a couple of things as we dive into the question. So several things you hit on: intersectionality, location, lived experiences. I cannot highlight enough how that is so important, and I hope that our the the attendees understand why that isn't so important. And so Kimberly Crenshaw talked about intersectionality, and it has been used and broadened since she brought that to the impact of class, gender, and race. And there are so many other intersectionalities, and our location, my lens, your lens, that we bring to that table. And so, um, if you could talk a little bit about our white brothers and sisters who do not have this, I hate to use the word marginalized, but those of us who are not of the majority, right? They don't have this lens that they can. So how do you help? What is it that they can do to ascertain more of this humility, more of working, particularly within the refugee and immigrant, but just in people of color in general? What would you say to our white brothers and sisters around what they can do in order to be better when they have to face? Because you and I both know there are not enough of us, whether it be in your community or my community or other Black and Brown communities, to work in those communities. So, what would you say?
Thank you so much, and it's so wonderful to have you here. Thank you. What I say is what I will, I'm sorry, I'm going to just go to my MSW students. What I say to MSW, I've been teaching this course on diversity for 8 years now. This is my 9th year. And one of the things I say my students when they came, and those are students who are ready, to go out in the world and become clinicians. So what I say to them, they will come in the beginning, my white students, and they will say, I'm so ashamed, feel so much guilt because of my privilege, because of where I come from, because of the harm that was done to people of color, to Black and brown people. And so what I tell them is really your guilt and shame is useless to me. It's not going to make the world better. So I want you to cry as much as you can today, but I don't want to see that again. Let it go, okay? So let go of, we can either let what we don't know, what we don't have, paralyze us, or we use it as a way to create more equitable and just world. And so what I will say to them is actually is every one of you on this, write down your own privileges, write down your cultural influences, write down your legacy. I was born here. This is what I do. This is who I am. This is how I see the world. And look at the communities you serve. And actually, even talk to them, say, tell me. So I grew up in the Midwest in a small town. Everyone was Christian. We all did farming. Yeah, we had these values around, uh, that if you work really hard, you are going to succeed. Things that actually don't work for Black people. That's what we know because we work hard and still nothing. But so I think like just write down your own values and talk to your clients and ask them what are the values that have made this community. What are things I should know? I actually say. Yeah, know the toolkit. What are not only what are the healing practices, but what are the core strengths? Never ever go as a helper if you don't go first as a learner.
Absolutely. There's a saying, Dr. V, thank you for that answer, is that people don't care what you know until they know that you care. And so I come in
Absolutely.
with this love edict, right? That my clients know whether I'm speaking in an organization or whether I'm speaking in that I love them and I want everyone to be better.
Yeah.
And so thank you for that.
And I
Um,
just want to add one thing. So to be better, I need to build on what they already have. I don't want to martyr someone who comes in thinks they're going to give their life to support my community. I don't want someone who thinks they know what's wrong with my community. I don't want to know someone who knows what's right for my community. I want to know someone who says, you guide me. You tell me what will work here, what will work for you. And I have the skills and access, but you have the knowledge that will make the skills and access work. And that's where the partnership is so important.
Yes, and you use a term, you say cultural brokers. I've been using the term credible messengers, which is basically the
It's the
same
same.
thing, right?
Absolutely.
It
Yes.
is partnering with those individuals who are in the community, who that people feel safe with. And it goes back to something you just said. around lived experience, believing the lived experience. And so oftentimes there are therapists who come in and they talk about they not believing, right, what is being said or looking at it through their lens. And so that downplaying of their own experiences, their own privileges, so that they can become intertwined into what we understand and not them. And so there's a comment in there about expecting people of color to educate me. And so um, I'm going to say a little bit about that, and then I want you to say a little bit about there's a difference between being curious versus wanting me to educate.
Yes.
So for instance, as I said, I don't know, I mean, I'm not competent in my own culture, right? Because we're not a monolithic, Black people ain't monolithic, right? We come from all different areas. And so asking open-ended questions. So for instance, I was talking to a young lady yesterday and she was telling me about things that she wanted to do. And she was trying to make a decision, right? So we don't make decisions for people. And so I just asked the question. I said, do you have any spiritual or religious beliefs? Right. And she's like, well, I'm a Christian, even though I don't really go to church. And I said, well, how does prayer factor into, right? So it really is about just being curious. So as when people say things, if you ask questions that are related to what they're saying, you can learn without making them, quote, educate you, right? So it's through the curiosity in your questions, right? Versus making the assumptions about what they're saying, you continually ask those questions. How would you address that, Dr. Abdi?
I actually love everything you said, and I will agree. I will say, and I love that what you started with, which is the difference. If you're going to the Black community and saying, educate me for my own growth, that is not what we're saying. If you're working with a community or a client, learning about them before you propose, because otherwise you're literally proposing things that may absolutely have nothing to do with their lived experience. So learning about them for the purpose of actually saying, is this thing I'm going to suggest work, given this? Curiosity and humility go together. Okay, those two things, carrying two things together. And yes, not making the community work for you. And you should still do cultural competence. For example, everyone on this should know the experiences of refugees. What I just talked about, the phases of the types of trauma they're exposed to, the phases, how trauma here, discrimination is so impactful. All of those you should know. So you shouldn't go to your clients and say, tell me, what kind of experiences do refugees have? You should know that already, but you should ask them, tell me about your experiences. So I understand what you need and how I can help you.
Absolutely. And so there was a comment around the beginner's mind. Absolutely. But I like curious mind, because beginner connotates that somewhere you're not going to be a beginner, right? Whereas curious mind is, I don't care how much you learned, you should always stay curious, because for as much as you think you know, you don't know, right? The other question that was asked around assimilation versus acclimation, right? One of the things that I talk about when I'm doing clinical supervision is when I'm training therapists, I train them to say that everyone who walks inside of your um, office, organization, has had trauma, whether they understand it or not, whether they recognize it or not, whether they acknowledge it or not. We have all experienced something that has impacted us in a way that has changed, right? How we see and the way we do things. So we should always be entering and thinking from a trauma informed. But the other thing that I've also come to realize from doing this for 20 years and doing workshops around trauma is that even therapists don't understand truly what trauma is. And they don't know how to deal with it. And so what are some of the question around acclimation versus assimilation? And then the second question around um, how people are to understand what it means to be trauma informed and creating that safe space.
So I don't actually do assimilation is something we try to stay away from, especially in trying to help refugees and immigrants. We really want people, the whole theory around acculturation of, assimilation, integration, and so on. We do research. Actually, I do research on it all the time. And number one, there is no linear process for people. But two, we actually research shows, even my research on Somali kids, that keeping your culture and having strong ethnic connections, healthy connections, is protective. So trying to change people to become assimilated is an unhealthy thing, and it increases the potential of acculturative stress, which we talked about.
Absolutely.
Because so for that is acclimation. If you're talking about how people become knowledgeable about the culture, we want people to be able to know how to survive in this culture. We wanted them to be able to speak the language, to be able to speak other people from different from them and get along with them, because that's actually part of the, what allows to have people to have happy and healthy lives. So if it's adjusting to living here, then that is a good thing, and helping people, once they arrive here, to some of the work I do and around resilience is actually, I just want to say this resilience is about this idea of keeping close bonds to your own community. So if you are a refugee, so your own refugee community, and then having this bridge to other communities. So being able to connect with communities that surround you. So for example, many of the Somali families live around the African American community. So ensuring that kids are acclimating and learning and integrating to those communities, and then ensuring that people are linked to services and systems that make life easier. So in that sense, then we want to be able to acclimate, but not to assimilate.
Right.
That's not something we'll promote.
Absolutely. Again, are there, what would you want, 2 or 3 things for our participants to take away and to remember from what you said today that they can use practically in their practices as well as their organizations when they're working with communities of color, when they're working with immigrants, when they're working with refugees? What are the, say, top 3 things that you would like people to go away with?
So one, to start with yourself. If your assumption is your biases, your inability to understand how your own upbringing may be actually harmful, if you don't examine, address, constantly monitor that, we're done. You're not going to help anyone. So start with yourself, with the cultural humility, look into yourself and work on that constantly. And I love what you said. I want to repeat it. Actually, one of the basic tenets of cultural humility is a lifelong learning. Every day you restart, you continually remind yourself of the things. And if you do harm, recognizing it, addressing it, apologizing, but changing the practice. And do cultural humility with yourself and with your institution. Your institution is part of you. I know it's very hard, but we have to continually try to do it with ourselves individually, but also with the institution. So that's one. Number two, relationships. We talked about this. Building relationships with communities, with community institutions that are trusted, having cultural brokers who bridge relationships. If you go to to the masjid, or to the church, or to the temple, like we used to bring a whole group of providers every summer to tour the Islamic Center in Boston, because we want them to see where our communities, how they live, and we do the training. Actually, also do home visits and neighbors. A lot of our providers don't live in the communities they serve. If you don't know where people are living and the lifestyle, what it takes for them to come to you and to actually adhere to a treatment, you cannot work with them. So cultural humility, then relationship building with across the board with the individuals, but with cultural brokers as well as or trusted liaisons, and with the institutions. But finally, safety, safety, safety. Do no harm. You cannot heal if you do not stop the harm. We can only start healing when we are no longer being traumatized. So stop the trauma, do whatever it takes, whatever you can. So make sure that your institution is not re-traumatizing, okay? And then work in the communities to make sure that we're getting support to stop the trauma. So those are three things: humility, relationship, safety.
Thank you so much, Dr. Abdi. Thank you so much, Gwen, for this wonderful and insightful and enlightening conversation. At this time, we will be breaking for lunch. Please note that there is a link. So for people who want to continue to dialogue and have open conversation with each other around what has already been said, there's a link that you can join, and there can be lively conversations while you're eating lunch. So you should see a lunch link for those who want to continue the conversation. Lunch will go from 12:10 until 12:45. Again, you will log out of this, log into the conversation lunch link if you want to have lunch and conversation. Otherwise, you will log in at 12:45 on the impact of trauma on the Black community, which will start promptly at 12:45. Again, thank you for this morning. Thank you for everyone who has been in attendance since 8:45. This conversation so far has been wonderful, and I look forward to continuing it this afternoon. Thank you again, Dr. Abdi, and thank you again, Gwen. And I will see you at lunch or afterwards.
Thank you, Anne. Thank you so much. I appreciate it. Thank you, Gwen. Thank you, everyone who is on this call. Thank you. I appreciate you. I'll see you. I might join the lunch discussions.
Okay,
So
great.
thank you
All
so
right.
much. Have a
All
wonderful
right.
day.
Bye-bye.
Thank you. Bye.